All right, good morning, everyone, and welcome to our first Building Healthy, Strong Communities virtual conference session. This is COVID-19, Ethics and Social Work Implications with Monica Rich-McLaurin. Thank you for joining us. We are going to get started here in just a couple minutes, but before I've just got a couple housekeeping notes. So in order to receive your CEUs, you do need to stay for the whole duration of the webinar. It's going to be an hour and a half. And in order to receive those CEUs, you need to stay for the full time. We are going to be having some poll questions periodically throughout today's session. Again, in order to receive your CEUs, you need to respond to those poll questions. If the poll does not work properly for you, go ahead and put your answer in the chat. And then finally, the evaluations will be sent in about 2 to 3 business days, potentially a week, after the conference has happened. So please give our continuing education office some time to get those CEU evaluations out to you. And if you have any questions, I'm going to put the email address in the chat for who you can reach out to if you have any questions about your CEUs. So before we get started, I just want to take a minute and introduce today's speaker. So this is Miss Monica Rich-McLaurin. She is a seasoned social worker with more than 25 years of experience and has worked with the entire lifespan in a myriad of settings, from foster care, outpatient mental health, inpatient mental health, to community outreach and assertive community treatment services. Monica is the CEO and founder of Paramount Counseling Group, which provides accreditation preparation services to organizations that provide behavioral health services, children and youth services, and opioid treatment programs. Recently, November 2020, Monica was appointed the chairwoman of the National Association of Social Workers, NASW, National Ethics Committee, where she is charged with assuring the ethical integrity of the social work profession by participating in professional reviews where ethical violations have been alleged, as well as assisting in the revisions of the NASW Code of Ethics and Professional Review Manual to reflect current practices. So we are very fortunate to have Monica here with us today. She definitely knows what she's talking about when it comes to ethics and social work. So to get things started, I'm going to pass this on over to Monica, and we can get this show on the road. Monica, the floor is yours.
Great. Thank you so much, Emma, for that introduction. I'm so glad to be here with you all this morning to talk about what else but COVID-19, right? So I'm just going to go ahead and share my screen with you all so that we can get started. So the title of the presentation, as Emma said, was COVID-19 Ethics and Social Work Implications for Practice. Here. So clearly, we all know that we are in strange and unprecedented and anxiety-producing times since the media began discussing this strange coronavirus, or COVID-19, as we soon became to know it. In January of 2020, there were reports that there was an early signal that the world as we had come to know it would be changing. However, I don't think any of us really realized to the extent that it would change and the duration that it would change for. And then if you fast forward 4 months from January of 2020, many of us were put under stay-at-home orders by our local governments, where we were mandated to stay at home and to stay away from our loved ones in order to protect them. However, more importantly, we were called to action as social workers to implement an effective yet safe way to continue to provide services to more vulnerable populations. This challenge was met on all fronts, but at the same time, we questioned, how do we safely provide services? How do we maintain client confidentiality? How do we make our clients comfortable with utilizing a cell phone to receive services? Is there a learning curve for our clients? And do they have the appropriate equipment to support telehealth services? If I can touch on a moment for how do we make our clients comfortable with utilizing a cell phone to receive services? For the population that I work with, I currently work with a severe and persistently mentally ill population, where some of their diagnoses come along with auditory and visual hallucinations. So we are now asking them to look at a device that they can hold in their hand where they see our face, and we want them to show their face so that we can continue to monitor their progress and provide any interventions necessary. That, I believe, at least for myself, has probably been the biggest challenge. And I'm not sure if the rest of you have been having that challenge, but it certainly is one that I have personally observed. So some of the challenges that we have with telehealth, as I mentioned before, some clients that do have cell phones may actually have poor reception depending on where they live. Typically, more rural populations and areas tend to have poor reception. Many of our clients don't have internet access. Some people actually have the old school flip phones that don't have internet access. Those that do may not have sufficient internet access to be able to support platforms such as Zoom and Doxy due to data restrictions as well as reception. And then even in providing telephone contact, many of us, self-included, do no longer have landline phones. And then lastly, many of our clients tend to change their cell phone numbers frequently, which makes it more difficult in contacting them. Also, we also know as social workers that changes in the delivery of social services normally takes years, emphasizing the word normally. However, there are exceptions where political direction coincides with the aspirations of the communities and social services workforce, but these are rare. The journey over the last 13 months is something new, a change at a global level caused by a pandemic where social workers have been and continue to be at the forefront advocating and leading change in nearly every country. Emma, can you launch the first poll?
Okay, so just as a reminder, please do respond to the poll to receive your CEUs. I did forget to give you guys 2 polls at the beginning, so just continue to respond in the chat about how you are affiliated with the School of Social Work, as well as whether you are a researcher, faculty, practitioner, student, or other. All right, I'm going to give you guys just a couple more seconds, and then we'll end this poll.
Thanks, Emma. So 51% of you said that in March of 2020, social workers were considered first responders per state guidelines, and 49% said no, that we were not considered first responders per state guidelines. And the actual answer is that no, we were not considered first responders initially upon the initial rollout of vaccinations and prioritization of receiving PPE equipment and things of that sort. It was shortly thereafter, however, where we were considered to be first responders. So I thank you all for participating in that poll. Ethical challenges. So as social workers, we all know that we are crafted and designed to be able to spin on a dime, adapt, and implement a program or a protocol as needed. However, COVID-19 has created a different layer of challenges for us. Many of us, the social work profession as a whole is primarily in-person contact, whether we're doing a home visit or whether they're coming into our office to receive services. So now with quarantines, stay-at-home orders, masking, and also just the personal apprehension of the clients that we serve, we are presented with the challenges of creating and maintaining trusting, honest, and empathic relationships via phone or internet with due regard to privacy and confidentiality, or in person with protective equipment. Now, I want to definitely focus a bit on the relationships via phone or internet with regard to privacy and confidentiality. Unfortunately, some of us as practitioners deal with individuals who are in domestic violence situations. So many of us are faced with, is the assailant or is the perpetrator of the assault in the room, but we just can't see him or her? Those are challenges that we are still working to overcome. However, I will certainly say that my colleagues who specialize in that area have done an absolute amazing job in trying to observe physical cues and being able to take action when necessary. Another challenge would be prioritizing service user needs and demands, which are greater and different due to the pandemic when resources are stretched or unavailable, and oftentimes full assessments are nearly impossible. Balancing service user rights, needs, and risks against, hang on, I'm just moving my picture, against personal risks social workers and others may face in order to provide services as well as possible. So, of course, telehealth is something that we've always heard of, but typically it's something that's done by our psychiatrists or primary medical physicians. We didn't hear of social workers providing telehealth until March of 2020. So, when that happened, we had to make sure that A, our malpractice insurance would cover us providing such services, insurance companies would cover the provision of such services, and also for how long. Additional ethical challenges include deciding whether to follow national or organizational policies, procedures, or guidance, existing or new, to use professional discretion in circumstances where the policies seem inadequate, confused, or lacking. Now, many of us work in traditional settings where you have your ordinary policy and procedure manual, but prior to March of 2020, I would bet that about 90% of you have not seen clear documentation on the implementation of telehealth for clinicians. However, that has now since changed. And there's also a sense of internal conflict when we look to uphold the National Association of Social Workers Code of Ethics versus our organizational policies. I've had the unfortunate experience of hearing of some colleagues who work in the hospital setting who have essentially been told, regardless whether you're sick or not, whether you have symptoms or not, you come into the office, you provide those services, which is a clear conflict between what our internal struggle is assuring our own personal safety while providing quality services, but being under such a mandate that seems so inhumane and insensitive is certainly concerning. Also, acknowledging and handling emotions, fatigue, and the need for self care when working in unsafe and stressful circumstances. So, again, I'll use the hospital as an example. When we're looking at individuals who are coming into the hospital and end up on a ventilator, those are clearly stressful situations. When we have to go in and have conversations with that patient, and then in turn leave the room and go out and have conversations with the patient's families, if they happen to be allowed into the hospital, those can be extremely stressful and emotionally taxing on us as social workers. And for those of my more seasoned clinicians in the audience, we know that we must take the time to compartmentalize our work experience so that we don't take that emotion and that fatigue home to our families. The need for self care. For those of you who are NASW members, the Code of Ethics is currently being reworked and modified to add a component on self care in order for us as social workers to have something that backs us up. When we say that we need a mental health day, we'll now have a code of ethics that will back us up and support us in doing so. And using the lessons learned from working during this pandemic to rethink social work in the future. I can't emphasize this one enough. And this is not only in social work, but it's across the board. When we look at individuals who work for the big three, for example, they have typically gone into a brick and mortar building to do their work, to do their job, but the job could technically be done at home. The big three is now given that provision to a large majority of their workforce to be able to work from home. And what they're noticing is that their staff are more productive, they're happier, and they're more engaged. The same thing applies to social work. We're more productive and we're more engaged. So when we think about this, we have to look at telehealth, is it really so bad? I know, at least for a personal share, one employer that I worked for, myself and a colleague of mine advocated to do work from home because we did primarily macro social work, which is more performance improvement, quality improvement. And it was met with significant opposition initially. However, our leadership finally said, okay, we'll let you do a hybrid. And the hybrid was definitely much more effective. When you think about when you're in the workplace, you have to think about your coworkers coming by your office to say how the weekend was, or to say, hey, let's go get some coffee, or hey, let's go to lunch. What are we ordering from lunch? Those things take time out of your productive day. So when you can be in the comforts of your home or your home office providing services to people, you are more at ease because you don't have to deal with the transportation, the commute, the rush hour traffic, and the stress that comes from that. So hopefully, these lessons learned from this pandemic will certainly impact the way that we do business in the future. So, in person versus telehealth, the social work dilemma. The National Association of Social Work has codified professional values, principles, and standards, also known as the Code of Ethics. And recently, the NASW president referred to the code as well as social work's dual focus on people and community. And she offered this. As social workers who adhere to the National Association of Social Workers Code of Ethics, we need to be aware of our obligation to provide appropriate professional services in public emergencies to the greatest extent possible. In doing so, we advocate for the needed resources and policies related to supporting members of our communities and the people we serve who may be at risk due to accessibility of food, medical care, medication, and emotional support during this time. Emma, can you tell me when my next poll question is coming up, please?
We were going to do it in about 3 slides.
Perfect. Thank you. Feel free to interrupt.
Yep, no problem.
Great. So some of the values directly from the Code of Ethics that we need to strongly consider are the value of service. Our primary goal is to help people and to address social problems, right? So in the midst of COVID-19, we are still looking to help those individuals who need our services and to be able to address those social problems with them as well as for them. Many people complain about the lack of appropriate testing or the lack of appropriate vaccinations or being eliminated from a vaccination group because of age or because of their zip code. Those are the type of things that social workers immediately enact and engage with the change agents and the individuals who make these restrictions and parameters to address those problems. The value of social justice. Social workers challenge social justice every day, all day, even more so now in the midst of COVID-19. There, as you'll see later in my slides, there'll be some discussion about some disparities and also why some people are opting to not receive the vaccination. So in that, social workers challenge those social justice issues on the local level, the state, as well as the national level. The value of dignity and worth of the person. The end all be all and the foundation of what we do is to respect the inherent dignity and worth of the person. At no time as social workers, whether virtually or in person, shall we diminish their dignity and worth because they are in need of services. So, what needs to be done? What actions need to be taken? What actions need to be taken by social workers, social work employers, and by government, and also by our professional organizations? So we as social workers, we need to rethink how to apply professional values and principles in the new context. We need to engage in ethical deliberations with colleagues. Again, having those water cooler conversations virtually to discuss some of the challenges that we face in providing services. And for those who provide services in person, definitely have those conversations with your colleagues, particularly in areas that are of grave concern to you, such as availability of personal protection equipment. We also need to be aware of the impact of exhaustion and emotion on their capacity to see the full ethical implications of situations and to treat people with respect, empathy, and compassion. And we need to raise with employers, professional associations, and policymakers the serious harms and inequities experienced by people during this pandemic and the difficulties in delivering social work services and proposals for improvements. Some of these challenges and proposals for improvement include the access and availability to technology. Some of us work in offices where we have a desktop computer. So, in the midst of COVID, some of us as social workers are going out and buying tablets so that we can appropriately engage with the people that we serve. This is something that we need to engage with our employers to say, we need additional funding so that we can have office issued equipment to provide these services. Social work employers, the actions that we need from them to ensure that all social workers and students on placement are supported through regular supervision and team meetings. These regular supervision and team meetings give opportunity for social workers as well as students an opportunity to debrief about the things that they've seen, the things that they've heard, the stories that they've heard, the impact on the clients that we serve. I can tell you now from my current caseload, I have seen a minimum of 15 individuals who have lost someone due to COVID-19 or have actually had COVID-19, and to give them that opportunity to express their feelings, their fears, their emotions, the fear of sharing the virus with one of their loved ones who may have a compromising medical problem. These are the perfect forums to be able to do that. Also, employers should develop guidance with frontline workers about how to operate safely and ethically. Sometimes our employers know that we're social workers and they know that we provide therapy, but they don't know the nuts and bolts of exactly what we do. So we need to let them know what we need to operate safely. And don't hesitate to pull out that good old NASW Code of Ethics and say, according to 6.04, this is what I need to govern myself by, and have a discussion with your employers about how at times, the code of ethics can cause competing demands with organizational policies. Monitor levels of stress amongst staff and ensure adequate rest and recuperation. As all of us have heard in the media, nurses are at a significant shortage right now because of the increase in inpatient beds being occupied due to COVID-19. Nurses are not the only short staffed industry in healthcare. Social workers, technicians, EMTs. There's a multitude of other professions that are in high demand. With this demand comes an increase of stress among those who are able to be at work and are able to provide these services. These staff individuals oftentimes feel the need for the mental health day, even before COVID-19, just due to the nature of the work that we do. So employers should assure that we have enough opportunity and time to have adequate rest and recuperation, or as I like to call it, recharging the battery, so that when we come back at 100%. Provide necessary hygiene, equipment, and safety measures. I think you all can recall the mad rushes to Walmart, Meijer, Kroger's, Costco, Sam's Club to get Clorox cleanup wipes, Lysol, hand sanitizer. These same types of equipment need to be openly and readily available to us in the workplace. Also, employers should advocate to governments and draw attention to gaps in welfare systems and the need for improvements. And on a local level, I actually have worked within the Detroit Wayne County Integrated Health Network in the past, and I know that there are some initiatives on that level to approach the state to say, hey, this is what we're noticing within our region, and these are the things that we need to be able to effectively do our jobs. So I strongly encourage every employer to collaborate with some of your other colleagues in the field to implement that change. Actions needed by professional organizations. Our social work organizations, such as the NASW, have key roles in highlighting systemic factors, putting some populations at risk, and the vital role of social safety nets. Also, intensifying efforts to collect evidence on conditions for social workers and service users. This information is so important to us. We need to know what the trends are looking like in a particular area. Not to say that we would protect ourselves any less. However, having that knowledge going into situations definitely makes us govern ourselves accordingly. Advocating strongly with employers and governments to recognize social work roles and provide better guidance for maintaining services. In January of 2021, when President Joe Biden was inaugurated into office, I had hope at that time. I had hope not because Joe Biden was our president. I had hope because his daughter is a licensed master's level social worker. I said to myself, maybe she can bend his ear to what we as social workers on the front lines in our local cities, states, organizations need to be able to provide better services. Also, continuing to develop ethical guidance for social workers and employers and spaces for peer support and learning about ethical dilemmas in practice. For those of you who are NASW Michigan members, I know that there are several subgroups that come up with regards to COVID and peer support, and I encourage you all to take advantage of those. Those are the perfect forum to participate in a Zoom meeting where you can hear other colleagues indicating areas that they struggle in. And it helps because we learn that we're not alone in our struggle. We learn that there are other people who are also having ethical dilemmas about how do I uphold the code of ethics, but also how do I provide this service for my client, or how do I maintain the boundaries placed on me by my organization.
We've got our second poll question, and I think we wanted to take a brief pause for some questions.
Yes.
Perfect. So while you guys are responding to those polls, all right, Monica, our first question. So whether it's ethical to ask clients who have chosen not to vaccinate to continue scheduling virtual visits if we return to in-person appointments in the fall. If COVID levels remain high, to what extent do social workers have the responsibility/right to keep both themselves and others safer by trying to limit having unvaccinated people in close quarters for individual appointments?
I would say that it is ethical to do so. Vaccinations are a personal choice, and they are something that, many individuals have apprehensions about for a myriad of reasons, some of which we'll go into later in the presentation. However, social workers, we have to not only protect ourselves in our in-person office, but we also have to protect those who come into the office behind that unvaccinated individual. So by continuing to provide virtual services, I think is more than appropriate.
Great. And if you're not seeing the poll, the question is, do we as social workers face challenges in providing virtual services using platforms such as Zoom and Doxy? Please answer yes or no in the chat if the poll question is not working for you. All right, Monica, here are the results of the poll.
Okay.
And I've got 2 more questions for you.
Great.
Okay. Wondering how therapists working from home manage with young school-age children on Zoom school. Impact on clients and children?
Wow. Okay. So, I don't have children personally, but I do have a dog who's thankfully resting right now, but you may hear him barking later in the presentation. But, that has been a continuous challenge for my colleagues who do have school age children. And, they're trying to balance their full-time job by working as well as making sure that their kids are staying focused. The challenge is going to be there. Some people have actually gotten like older cousins or somebody to come and sit with the younger kids just to make sure that they're staying on track while mom or dad is doing their work at home in their home office, just to prevent the interruption. I think that especially with providing telehealth services, interruptions should be kept at a minimum. Oftentimes when we're in person, we might see a text message on our phone or our phone may ring and we can just hit decline or ignore. But when we're in a session with a patient, the last thing in the world that you want to see is a kid coming in saying, "Hey, mom, can you help me with my math problem?" Because it's distracting to the client that we're serving. And depending on the information that they're sharing, it could actually derail them from continuing to share. I've noticed that a lot of my clients are sharing much more personal and vulnerable information during this time. And I think because it's because COVID-19 has made us so vulnerable. We don't know what this disease does outside of ending lives, but we don't know what the vaccination does in the short term and the long term. Myself personally, I'm fully vaccinated. That was a personal choice that I made, but we don't know what's going to be the long term effect 5 or 10 years from now. But personally, I would rather have it and not need it as opposed to need it and not have it. I hope that answers your question.
Thanks, Monica. Okay, last one. With diversity, equity, and inclusion in the workplace, how can social workers get support when advocating for clients as well as within their personal organization?
Wow, that's a good question. I would say, again, social workers as a whole, one person might squeak the wheel, but several of us are going to make that wheel just roar. And I think the more people that we have who are on the same page with us in terms of assuring that our clients are receiving the appropriate services, regardless of the color of their skin, their gender, their age, their health condition, I think that that's definitely going to be an area where we as social workers are going to need to continue to work even after the crisis of the pandemic subsides. The disparities that I've seen, again, as I said, I was going to go into later in the presentation, have been very shocking. And some of the reasons why these disparities exist are also very shocking. And you sit there and you read these articles as social workers and you watch these news reports as social workers and you say, I can't believe this is happening. But again, all of us are sitting at home saying, we can't believe this is happening. Get with your colleagues, reach out to your state chapter of your NASW, reach out to your organization's diversity and equity inclusion programs, have those discussions with them, but also be prepared to come with some suggestions. A lot of times, if you're going into major organizations such as hospitals and you're saying, okay, we're seeing all these disparities here, why is that? We also need to come with the solution. Oftentimes, leadership in healthcare industries are not thinking that far ahead, whereas we as social workers, we're so adaptable that we need to have that solution right there, ready for them to at least say they will consider. Hope that answers your question.
Thank you very much. I think we're ready to move on.
Great, thank you. So, actions needed by government. So, I touched on President Biden and his daughter being a social worker. But governments need to recognize the critical role played by social workers in providing and supporting social and community-based care during the pandemic. So, previously I asked the question about were we as social workers considered as first responders? And the initial response was no, we were not. And, it definitely made the hairs on the back of my neck stand up and thinking, why not? We service people the same way that nurses service people, that doctors service people, that food service workers in a hospital service people. We should be afforded that same right to be recognized as a first responder, which we later were. But again, it took some social workers squeaking that wheel, making it roar. We also need to, governments also need to acknowledge social workers as key workers. And I believe that they're getting there. I've always said that the profession of social work has been so under recognized in our communities and our state and national levels. I'll never forget when I went into the field of social work and I told some friends, I said, yeah, I'm a social worker. And they said, oh, okay. So you help people get food stamps or you help people get Medicaid. And when I took the time to explain to them the breadth of the social work profession, they were like, oh, wow, I really didn't know that that's what you guys actually did. So it's also about educating people so that they know exactly what we do. Ensuring the provision of necessary hygiene and protective resources. We've all heard the stories on the news and in the media about inadequate N95 masks, lack of availability of rubber gloves, of protective equipment, of masks. I think I heard something in particular about a local hospital that would not allow their employees to bring in their own PPE, but they didn't have the appropriate PPE for the staff to provide to do their job. I thought that was absolutely appalling. If you have staff members who are able to access and bring in those N95 masks, let them do that, especially if you cannot offer them what they need. Government also needs to issue clear guidelines on how to maintain social work services during a pandemic, keeping services open while operating as effectively and safely as possible. While I don't think that on the national level we've been given those guidelines, I certainly think on the local level that our governor in the state of Michigan, I'm not sure if we have any out of state people here, but Governor Whitmer, I think, has done an excellent job on providing guidelines around different service industries and how to be able to be open and provide services. But all I can say is thank God that COVID came when it did. And when I say that, I'm not saying that I'm glad that it came. I'm saying that I'm glad that it came during a time where we have internet service, cell phones, all this technology that's available to us, Zoom, FaceTime, Google Duo, all of these different platforms to still be able to engage with people. If you can just take a moment, just think about if COVID-19 had surfaced 25 years ago and what that would look like for us. We would be challenged ethically with, do we go door to door to provide services and do it 6 feet apart? How is that maintaining confidentiality? So, COVID 19, albeit none of us wanted it here, but it's here. And I'm just grateful that we do have the platform to be able to continue to provide those services as seamlessly as possible using our internet access and variable platforms. I had to take the time to talk about the resiliency of social workers. I got my MSW from U of M, and I noticed within my cohort that many of us struggled with personal issues, professional issues, and ethical issues. We, as a cohort, were able to adapt and modify our strategies to get things done through group work. We were able to do it using the internet when I got my MSW. But in these times of uncertainty, we continue to strongly advocate that governments must prioritize investment in people, in social health, education services, and sustainability. And we can be confident that our profession will rise to the challenges ahead as we've already done. We've done it in the past, and we've been an influencer in the past. We've been a change agent in the past, and we can certainly continue to do so. Social workers across the world have faced similar and constant ethical challenges in the face of inadequate resources and collapsing health and welfare systems. For example, lack of personal protective equipment and appropriate technology to work remotely. In an article that I read I believe it was in Sierra Leone, accessing social work services was so low on the priority list of those residents of Sierra Leone. They were more concerned with getting food on the table for their families, making sure that they had basic essentials. They weren't thinking about therapy. They weren't thinking about staying away from the vaccination. They weren't thinking about getting a vaccination. They were thinking about the basic needs. And that's what we as social workers have always done. We have always paid attention to basic needs. We all know it's kind of social work 101. If your basic needs are not met, our interventions are not going to be as effective as they would be. Social workers across this world also took the pandemic as an opportunity for proclaiming their roles as advocates and facilitators for a more socially just world. It was an opportunity for us to reinvent social work as well as ourselves. And I know personally for me, it has been a major game changer in how I do business and how I engage with my clients. Initially, March 2020, when I shut down all in person contact, it was a matter of offering all of my clients the opportunity to work virtually. 70% of them openly accepted that, recognizing the need for continued services. The remaining 30%, kind of like myself, said, well, let's wait it out. Maybe this thing will be gone by summer 2020. However, by September 2020, when it was still hanging around and the numbers were getting worse, 15% of those 30 came back and said, we need you. So they are also engaging virtually. So it lets you know the value that you hold in their lives and the impact that you have in helping them to process issues that brought them into treatment in the first place. Now, we do know that socioeconomic status is directly correlated with increased medical issues, which could put people in the high risk category of severe complications if they contract the coronavirus. These factors only magnify these disparities. What are social workers and the national social work organizations doing to advocate for change that acknowledges and works to minimize these disparities? I've seen groups of people advocate for families, but what do you do if you don't have an advocate? What do you do if you're in the hospital with COVID-19 or some other serious medical problem? What do you do to try to advocate for these individuals who can't have visitors at bedside? What do? You put on that advocacy hat and that social justice hat, and you do what you do as social workers. You ring the bells, you sound the alarms, you identify these disparities, and you don't stop until they're acknowledged and until there is will and tread behind that acknowledgement of these disparities. Social justice issues surrounding COVID-19. And we do know that there are quite a few. Some of which, as previously mentioned before, poor populations lacking health services in normal circumstances are left most vulnerable during times of crisis like this. Right now, those who are in poor populations or lower socioeconomical status are struggling with, where's my next meal coming from? How am I going to pay my gas bill, my light bill? How am I going to pay for food? How am I going to make sure that there are clothes on my children's back? With COVID-19, we saw an influx of unemployment in our area. Many people waited 8, 10, 12 weeks to receive unemployment benefits. What did they do during that interim? Many of them sought assistance from their local Department of Health and Human Services. Some received benefits, some did not. For those who did not, what do? Many populations tend to gather and pool resources. So when you're pooling your resources and you're saying, okay, I've got the meat for dinner tonight. He's got the vegetables, he's got the starch, and pooling together. And as difficult as it is in the midst of a pandemic You can't dine together. You can't do these things together anymore. Well, at least in March of 2020, you couldn't. Now we're faced with, I'll leave it on the porch, or I'll leave it on a table on the porch for you to pick up, just to minimize that exposure to this deadly virus. Misinformation and miscommunication disproportionately affect individuals with less access to information channels who are more likely to ignore government health warnings. So, for those individuals who may only have access to local channels and not have access to CNN, MSNBC, Fox News, whatever your choice is. So, the lack of information promotes the lack of action in certain populations. With the introduction of physical distancing measures, internet coverage should be made easily accessible and affordable to everyone. Recently, actually, it was on Sunday, I was visiting with a family member and we were watching TV, watching the news, and there is an emergency bill that is out to defray some of the cost of internet costs. I believe it's $50 a month that would be paid on behalf of the individual household for internet access. I can't recall the name of it right now, Emma, but I will certainly put it in the chat before the end of this webinar so that anybody interested can certainly look at it and get some additional information. Additional COVID-19 disparities. We already know that the inequitable response to COVID-19 is evident. Healthy life expectancy and mortality rates have been historically marked, disproportionate between the richest and the poorest populations. But you know, the thing about COVID-19, it doesn't care about your color. It doesn't care about your bank account. It doesn't care about your trust fund. It has no name on it. The full effects of COVID-19 are yet to be seen while the disease begins to spread and continues to spread amongst the most fragile settings, such as congregate living facilities, nursing homes, and correctional facilities. As many of you know, there was a mass exodus of people from correctional facilities to prevent the spread of COVID 19. Some of them were more controversial than others, but nonetheless, they're doing what they can to flatten that curve. Additionally, as global economy plunges deeper into economic crisis and government bailout programs continue to prioritize industry, scarce resources, and funding allocation decisions must aim to reduce inequities rather than exacerbating them. Now, we've all seen the reports across the world where one country is getting a monthly stipend while COVID-19 exists, while here in the United States, we get $600 here, $1,200 here, $1,400 here. And we all know for those who are in the lower socioeconomic status, and if they have not received any assistance from their state programs or from the unemployment programs, that $1,400, that $600, that $1,200 is not even scratching the surface. While they like to call it an economic stimulus program, it's not really stimulating the economy. It's literally helping people to do their best to keep their nose above water. But why are so many people still not vaccinated? Availability of the vaccination in certain areas. I've spoken with several people who have had to travel upwards of 75 miles from their home to get the vaccination. But what if we don't have appropriate transportation to get there? How do we do it? Restrictions of age groups upon the initial rollout. We all know, we heard it. Individuals 65 and over can get the vaccination. Individuals 65 or over with comorbid medical conditions can get the vaccination. Individuals 70 or over, 75 or over can get the vaccinations. And I understand the reason why that was done because of the supply and demand. There wasn't enough supply to meet the demand of individuals who at that time wanted to get this vaccination. The restriction of first responders, social workers were initially included in that group. But even when you look at how long it took for our educators to be eligible to receive that vaccination, while at the same time dealing with their own competing demands of their school system telling them, you have to report in person to educate our children. The internal struggle that they feel, I can't even begin to imagine because they're committed to their profession just as we are as social workers. Retail, restaurants, are they all vaccinated? We don't know. But again, the initial rollout of the vaccination provided very little support for some of these industries. The fear of the unknown side effects of the vaccinations. This is something that I've heard personally and professionally about why individuals opt to not be vaccinated. A very close friend of mine indicated that he wasn't getting the vaccination because he mentioned the Tuskegee experiment. While I understand where his thinking is coming from. The Tuskegee experiment was done with a very narrow and focused group of people. It was done with African American males. It was not done with the entire population of the world. In addition, you hear the horror stories of people who've gotten the vaccination. Oh my gosh, the first shot almost killed me. That makes somebody a little reluctant to take the vaccination. Then the second vaccination, oh my gosh, I thought I was going to die. I was in bed for 4 days. I had a horrible fever. I didn't have an appetite. Those were reasons why some people opted not to take the vaccination. But what I'm noticing now is that more individuals are being exposed to individuals who have been fully vaccinated and are living to tell the story, if you will. And they now are considering receiving that vaccination. Also, as previously indicated, many individuals are facing financial hardships with job loss, transportation loss, basic needs not being met, which makes getting a vaccination much lower of a priority on their list. In addition, comorbidities such as heart disease and diabetes. Some people are concerned with my heart problem or my diabetes. Can I get this vaccination? If I do, how's it going to affect me? Right? We've all had those experiences. But as I said earlier, personally, I would rather have it and not need it as opposed to need it and not have it. Recent state and national statistics. I wanted to get the most recent numbers. So these are as of Saturday. In the country, 146 million plus Americans have received the first dose of the COVID vaccination, and 103 million are fully vaccinated. In the state of Michigan, as of April 30th, 4 million Michiganders have received their first dose of the COVID vaccine, which is representative of 50% of America's population, which is pretty impressive. As of May 1st, 940,000 Michiganders have contracted the virus, and nearly 19,000 have lost their lives due to this virus. Some of the disparities that were observed in some of my research preparing for this presentation. Between March 16th and October 26th of 2020, it was calculated that the mortality rate in Michigan was 5.4 per 10,000 population. When we look at race, the mortality rate amongst Blacks was 3.6 times higher at 15.6 per 10,000 than white populations. which was at 4.3. And then when we stratify by age, the mortality rate for individuals under 40 is 7.4 times that for white individuals in the same age group. 7.4. Among those aged 40 to 69 years old, the mortality rate for Black individuals was 18.4 per 10,000. 8.5 times that of white individuals. And while I said earlier, COVID doesn't look at your bank account, your skin color, but there's still the question of why. Why is this exposure happening at such a higher rate with this particular group? According to the CDC, 53% and 23% of all COVID deaths in the US are among white and Black individuals, respectively. That's a 30% gap. While these races represent 42.1 and 17% of the population, in Michigan, these disparities are even starker. While African Americans represent 14% of Michigan's total population, 35% of the COVID deaths in Michigan as of November 5th, 2020, and 35% of statewide deaths and 23.1 of statewide deaths as of January 21st, 2021 occurred within this group. Underlying this disparate burden are systemic inequities in socioeconomic conditions, health, and access to care by race, which impact that infection exposure and survival. Now let's take a moment and think about this for a moment. African Americans who typically reside in lower socioeconomic areas typically do labor jobs, right? So for those businesses that are still open or were still open, those individuals go to work. They go to work so that they can provide for their families, but they're putting themselves at risk every day by going into that work setting and being around other people, although social distance, but we all know COVID travels, which is why we social distance. But we honestly have to take a serious look at where and why these disparities exist.
Are you ready for some more questions?
Yes, I am.
Perfect. Okay. We have one that's sort of long, but I don't think it'll require a long answer. So,
Okay.
As social workers and other counseling professionals, we are now more than ever being asked to do more and more without compensation and respite. What can we do to truly advocate for ourselves? Early in your presentation, you talked about advocating for social workers to have mental health days. But when I return, I still have to do the work for the day off. Example, yesterday, I was scrambling all day to get my calls in and do preemptive calls because I wouldn't be in today.
Okay, thank you for that question. So the unfortunate reality with the field of social work in general, whether we take a vacation day, a mental health day, a sick day, vacation, our work always tends to wait for us because there are not enough of us in our industry to be able to provide an appropriate break where somebody can literally cover your caseload. And when I say cover caseload, I'm talking fully cover the caseload. I've worked in those settings before where I've gone on vacation and somebody supposedly covers the caseload. What they're covering are any emergencies that come up. They're not going to be maintaining that same degree of contact that I do. They're not going to be doing assessments as they're scheduled on my schedule. They're not going to be doing treatment plans. They're not going to be going out and reaching out to, individuals who are in adult foster care settings. They're not going to reach out to primary care physicians. So unfortunately, for the individual that asked that question, there's not a lot that is really different. Sorry about that. There's not a lot that's really different about COVID-19 and taking mental health days versus taking them prior to COVID-19. My hope is that with the modification and the addition of self-care into the NASW Code of Ethics, that gives us a bit more ammunition to be able to self-advocate and to advocate with our higher ups to say, okay, the code's been revised. This is clearly in here now. We've always spoken about self-care, right? We already know that. But now somebody's actually taken the time to realize it in writing into a formal code that governs our profession. So my hope is that with that being added, that will provide us a little bit more backing. Now, whether or not things will change on your organizational level, I honestly can't say, but I have worked for some organizations where they've actually had pairing of clinicians where we don't necessarily work together, but we work in the same particular niche. For example, previously I worked as an adult foster care case manager. So the other adult foster care case manager and I, we would work out our vacations between ourselves because we would always have coverage. Now, granted, we still didn't have um, the assessments being done, the treatment plans being done, things of that sort. But that's something that you may want to offer to your organization as a possible option. I hope that answers your question.
Thanks, Monica. Okay, we have two more. One, I'm not sure if you'll actually have the answer to this one, but we will see. So, why is it that there's an abundance of vaccines in Michigan, and my friends and relatives in other states have very limited supply and cannot get it? Teachers in some states cannot get it right away.
Thank you, Emma. So I wish I did have the answer to that question. Honestly, I don't know. I do think that it does boil down to a certain degree to your local and your state government. I'm sure all of you remember in Michigan when Mayor Mike Duggan refused the Johnson & Johnson vaccination when it first came out, and that was very short-lived. I believe there were some, backdoor conversations with our governor, and shortly after he said we'll take the Johnson & Johnson vaccinations. So honestly, I don't know why the supply and demand is that way. In addition, we've heard the stories of the two people dressing as old ladies to go to a different state to get the vaccination, and once they show their driver's license, they were discovered. So people are desperate for this vaccination. They really are, and they're going to any length to get it. So I'm sorry I couldn't answer your question as much as perhaps you would have liked, but hopefully it's something that will change. But I would certainly begin to inquire with your lawmakers in your area to find out, why is this not available here? And this is for the people that who live in the other states who are having problems getting vaccinated.
Thank you. So one more before we move on. How does COVID-19 mortality rates compare with pre-COVID mortality rates?
Thank you for that question. However, I did not dig that deep in terms of the pre-COVID mortality rates. That's something I'm more than happy to do and to try to get that data to you. If you want to send me a direct chat, I would be more than happy to see if I can get that information for you.
Great, thank you. I think we're ready to move on.
All right, great. So we have more interesting facts, more statistical information. So when we look at age, sex, and number of comorbidities, the mortality rate for African American population was higher than that for whites for every pairwise comparison. Among those with no comorbidities under the age of 65, African Americans have 12.6 times the mortality rate of white individuals. And Black males under the age of 65 with no comorbidities had a mortality rate of 6.2, where white males with no comorbidities in the same group experienced a lower mortality rate at 0.53. 0.53. The disparities are there. We all see them, but we have to get to the why. And we have to get to what do we need to do? How do we need to engage as social workers to close that gap, right? African American individuals represent 15.7% of the combined Black and white population of Michigan, yet accounted for 40.1% of COVID deaths during the study period of the article that I reviewed. 40.1% of individuals of color died due to COVID-19. African American females, the disparities were there as well. Without comorbidities, age 65 and older had mortality rates of 363.1 per 10,000, in contrast to white females in the same stratum who experienced mortality rates of 35.9. Do you see the disparity there, people? It's shocking. I heard about it. I knew it was there, but when I actually started to do the deep dig and the deep dive into research, these numbers startled me when I saw them. The relative difference in mortality rates is also stark when comparing Black and white individuals with comorbidities. Black males age 65 and older with multiple comorbidities had a mortality rate that was 3.5 times that of white males with multiple comorbidities. So here we get to the why. Go ahead, Emma.
I think we're ready for our final poll question.
Let's do it.
Okay, here it comes. So just as a reminder, if the poll is not functioning for you, please put your answer in the chat. If the poll didn't appear on your screen, the question is, what are some of the reasons for disparity in treatment for COVID-19 among minority groups? Not enough time, lack of transportation, lack of adequate coverage, lack of trust in the health system, or all of the above? I'll give you guys a few more seconds. And while I have your attention, we do still have a little bit more material to get through, but we will take one more Q&A portion at the end. So continue to submit those questions in the chat and the Q&A box. Okay, we're going to end the poll, and here are the results.
Yes, all of the above. You guys nailed it. You nailed it. When we look at not enough time, we look at our competing demands again. We have to work, we have to provide for our families. There's not enough time in the day. Many of the vaccination clinics, when they opened, were during traditional, what I like to call maker's hours. And it just was not, it didn't correspond with the schedules of individuals who perhaps needed it most. Thank you guys for answering that. So, why the disparity? And these are just a few things to think about. Clearly, this is not an exhaustive list. The stay-at-home public health guidelines implemented during COVID-19 are in tension with the need for stable employment, wages, and housing. Pandemic-related job losses have been experienced predominantly by those in lower income brackets, those in Black and Hispanic, Latinx communities, and those unable to perform work tasks at home. Pausing for a moment here. Working from home. These populations typically do not have jobs that permit them the opportunity to work from home. If they do they have the appropriate equipment at home to do so? Is it going to be more of a financial burden for them to purchase up-to-date technical equipment to be able to do it? Or will their job provide it? When a certain segment of the population is fundamentally unable to avoid the risk placed in position to ignore infection prevention guidelines, disparities in morbidity and mortality inevitably go up. We have to take a moment and pause and think about that for a moment. Think about to yourselves, what can I do, or what can myself and my colleagues do to minimize that risk? I know a lot of the big three have COVID screeners at all the entrances to all of their factories. They have screeners. That's great. But does it catch it all? No, because as we all know, we can be a carrier of COVID-19 and not know it and infect our entire family. That's the frightening part of this disease. That's the frightening part of this disease. Other possible causes. With the lower socioeconomic status, healthcare costs can create significant challenges for obtaining medical care, medical insurance, and oftentimes delay in diagnosis and treatments. We all know that healthcare insurance is going up on a regular basis, year by year. Our deductibles are going up because we need to be able to afford our premiums. With those high deductibles come the question to the individual, do I really need to go to the doctor right now? Do I really need to be treated right now? And oftentimes those in lower socioeconomic status say no. Perhaps that's a cause for the disparity. The results regarding the duration between symptom onset and hospitalization indicate that African American COVID-19 patients do not receive medical attention as promptly as their white counterparts, a factor which is known to influence survival. Financial barriers and distrust, deterring care seeking, the scarcity of tests, and racial bias among health providers may be driving this delay, among other factors. So again, it gets down to the nuts and bolts of access to care, trust in the healthcare system. Do you feel like you're going to be treated equally in the healthcare system? So in closing, though the situation is tumultuous right now, to say the least, there is hope. Social workers are experts in working in challenging environments. We learn skills that help us be collaborators, and we view the world through our own social work, social justice lens. Whoops, I didn't tell that to go away. There we go. We can make a difference. It's time to roll up our sleeves and social work. We've done it before, guys. We know how to do it. I know at U of M, when I was there were many times when we rolled up our sleeves and social worked. I was a part of the community and social systems and community organizing cohort, and we did it often in the community, grassroots. We must use the whole continuum of social work to do so. And I look forward to partnering with many and all of my colleagues to do this work moving forward, because it's hard work. It's not easy. And in the wise words of Elie Wiesel, there may be times when we are powerless to prevent injustice, but there must never be a time when we fail to protest. I believe that we are in these times, everyone. And let's assert the power of social work to work alongside communities to make a change. Let's do this. Thanks for attending. I'm opening up the floor to any questions.
Great, thank you, Monica. So we're just going to take a minute and wait for some questions to come in. So please do use the chat and the Q&A box. Sorry, they are mowing the lawn. I didn't want you guys to hear the lawnmower drive by. So please do submit your questions in the chat and the Q&A box. Looks like Nancy is giving you some kudos, Monica, in the chat.
Thank you, Nancy.
There was also a comment that I saw earlier, thanking you for the reminder to check the ethics updates regularly.
Absolutely, absolutely. And actually, the self-care component that we are to add was actually drafted by myself and two other colleagues who are on the National Ethics Committee. So you're seeing work right here from somebody in Michigan who had their hands in helping that to come to fruition. So while we are waiting for those questions to come through, I just want to remind everyone that tomorrow from 4 to 5, we'll have our closing reception, Connections and Conversations. It's hosted by the Alumni Relations Committee. And I see Judy Levick, who sits on that committee, just commented in the chat. So Judy, thank you for being here, and thank you for agreeing to host our closing reception tomorrow. I will put the link to register in the chat. So please do join us. Great. And thanks, Claire, for liking the phrase.
All All right, looks like we just got a question.
Okay.
In what ways can social workers routinely create education and awareness around the impact and history of structural racism?
Oh my gosh, that's a loaded question.
I was thinking the same thing.
Yeah, that's a loaded question. Wow. So, I think that if we look at the history of racism overall, it's not like a one source that you can go to really look at. You got to look at the history of it. You got to look at the whys of it. And then you also have to look at the whys of it now. Look at why does it still exist and why is it so intense right now? I know that many of us have different political views. I'm not going to get into the subject of politics, but I do know that there are some people who feel that they're more superior to other groups, and that's their opinion. It's okay. I don't judge. However, when it begins to impact the safety and the well-being of individuals, that's where it becomes a problem. And I think that that's where we need to wrap our arms around those groups when you see it. The violence against Asian Americans right now is a prime example of how we need to do more with this particular group of individuals to make them feel comfortable. I'm actually working with a client now who has a wife of Asian descent who's afraid to leave her home because she's afraid that she's going to be assaulted. That's a horrible feeling. She's not so worried about COVID-19. She's afraid that she's going to get beat up. What kind of way to live is that? But again, until we continue to demonstrate and protest and to challenge the status quo, we're never going to really be able to overcome this. Now, there's always going to be somebody in the basket of apples who's going to have an opinion contrary to the norm, and that's okay. But as social workers, we look to do what is right. We look to do what is just. And I think as long as we continue to do that, whether it's on a small level or a global level, such as the Black Lives Matter movement. That was something that was very pronounced all over the country, and I think it was very effective. However, we had the other groups of people who said all lives matter, and nobody's saying that they don't. But when you look into the media and you look at those individuals being assaulted, those individuals who are losing their lives due to law enforcement, we must take a look at that. We must take a look at the fact that if there's footage out there showing other groups experiencing the same thing, let's see it. We're more than happy to advocate for them too, but let's just see it. Make some noise. If you don't make any noise, then you're saying that you're okay with the status quo.
Thank you. Okay, we've got a few more that have just come in. Have you been in touch with social workers from other countries to have some sense of how our profession is faring elsewhere?
I have not had the opportunity to have direct contact with social workers in other countries. However, I do have a connection with a a member and leader with the International Federation of Social Workers. And she and I have had some conversations about some of the challenges. And again, I think more so in other countries, the challenge is the basic needs component that is of utmost importance to them before even looking at trying to protect themselves from this virus and trying to get vaccinated against the virus. They're looking at, weather impact on their food accessibility, and they're saying, we need to make sure that we have food regardless, and that's where their priority lies right now. So, a lot of times, therapy kind of falls by the wayside. It's almost kind of like when you look at your basic essentials in terms of your healthcare, right? So you see your primary care physician as needed. You reach out to them as, conditions arise. But if there's something that's going to have to fall off in terms of a priority, sometimes it might be our eye doctor or our dentist because we feel like, okay, our teeth are okay, our eyes are okay. We might have to wear some glasses like I do, but it's okay. But when you look at the competing list of demands, that's where people look at therapy as it's not a priority right now. The priority is making sure my family lives. But that's a great question. Thank you.
Okay, another one. Is the ACA helpful in reducing access to health care among those who have been distrustful of it? increasing rather?
So the ACA is definitely doing more in terms of making provisions for healthcare. However, the trust in healthcare cannot be changed with the ACA. It has to be changed by the vernacular in which the medical professionals are treating individuals. Um, I've heard horror stories of people being treated a certain way just based on the way that they look when they come in. Not necessarily the color of their skin, but just the way that they look. If they come in very disheveled, it could be presumed by medical professionals that they're homeless and they treat them as such. And it's unfortunate. I used to work in an emergency department. I've seen it. It's sad. I hate it. That's why I don't do it anymore.
Okay, and the last one, I just got my first vaccine. It took so long to get a call back. Do you think the lack of coordination affect people getting vaccinated?
Absolutely. Absolutely, it does. Now, for myself, I actually was able to get my vaccination in downtown Detroit at the TCF Center. And I must say, I was very skeptical about getting the vaccination in the city of Detroit because, things down there from, their parking system and, just any kind of navigating through that particular level of government is always a challenge. And I was very skeptical. However, I was most impressed with how seamless it worked. I mean, literally, you drove up, you gave your appointment time, you showed your ID, you drove in, you pulled up, you got your vaccination, you waited 15 minutes, they gave you a sheet with your next appointment time, and you were on your way. Literally, that's how it went. Now, in other areas, again, depending on if they're urban or rural, depending on the resources that they have, they may not have their system finally defined to be able to say, okay, this is what our system's going to be. Person A comes in on Tuesday for their vaccination. We have appointment cards already ready for 2 weeks or 4 weeks from now, depending on the vaccination that they receive. And we're going to give this to them. And, with the changes in staffing and volunteers, balls may get dropped in there where those callbacks don't happen. So again, as customers of this vaccination, we have to be responsible ourselves to say, hey, when is my next appointment?
I'm going to comment on that too. I had the same exact experience. I'm actually getting my second vaccine today after this at Ford Field, and I was extremely impressed with how organized it was. But I think that you're right. There's a large volume of people that they're working with, and they're humans. They can only do the best that they can. So, another question. Blacks who I know personally who died from the virus or contracted it had access to health care and quality of life issues. Socioeconomic factors were not issues, but they were affected. Is the virus attracted to Blacks regardless of socioeconomic status?
I don't believe so. I believe that African Americans and other minority groups are more susceptible to it just due to the nature of the work that they may do. You don't see an influx of African American and Hispanic Latinx population working in the big three at Ford in the white collar area. You usually see them, working in the retail, the restaurant, the productivity sides of the industry, which I think that's what makes them more susceptible to the virus. I don't think that it necessarily focuses on a particular race of individuals.
She followed up and said these were professionals. I don't know if that changes your answer at all.
Okay. Yeah, it really doesn't, because I mean, the research that I've done on COVID-19, it doesn't have, and I understand what you're saying in terms of they have access to the appropriate healthcare and everything. There's really no rhyme or reason of why, to be perfectly honest with you. Because as I said earlier, it doesn't look at your bank account, doesn't look at your zip code, doesn't look at your gender, doesn't look at your race, but it just happens.
Okay, we've got about 5 minutes left. Are there any other questions before we end our first session of the conference?
I have one.
Oh, go ahead, please.
I need to find out how I can access these comments from the chat, because I do see some in here that do require my response, and I do not want to neglect any of them. So I'm not sure how I can access those, but if you can share that with me, that would be fantastic.
Absolutely. It saves
Okay.
and will actually come as like a plain text right to my computer. So I will send it to you when we're finished.
Perfect. Thank you.
So thank you everybody for joining us. I did put the link to the conference website in the chat. You can access all the webinar links right there. However, if you did register, you will be receiving another email for the session that's going to begin at 11 a.m. And it's going to run the same. So make sure that you're there from 11 to 12:30 to receive your CEUs. And I'm going to give you guys just a few more minutes if you want to. We've got 5 minutes left, so please use this time to ask your questions. We've got some nice, oh, yes, the slides will be available. And just as a reminder, if you have any questions regarding your CEUs, when you're going to get them, if you didn't receive them, please reach out to the continuing education office. I'm putting their email in the chat. All right. Well, if there aren't any more questions, we will see you next time. Have a great rest of your day. And please do remember to register for Connections and Conversations, our closing reception happening tomorrow from 4 to 5 p.m. Have a great day, everyone. And thank you, Monica, so much for this wonderful presentation.
Thanks, everyone. Thanks, Emma, for the opportunity. Everybody have an amazing day.
Bye-bye.
Bye-bye.